Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of chronic kidney disease, part 2. Dr. Travis Brown, I think I understand why we're coming back for a second episode on chronic kidney disease, but we only did one on liver. We have 2 kidneys.
Excellent. Well done. Well done. You never know. We might end up go back to liver, and then that could be the transplant kind of thing, because livers grow back. So it all happens.
It all works.
It all works. Yeah, we are coming back to chronic kidney disease, part 2. And the reason why I separated these two is because, first of all, you need screening to be able to detect it. But there are some major causes of chronic kidney disease that we need to identify, we need to manage. And if we manage it well, then we're hoping to avoid end-stage kidney failure, and that's when patients need to go on dialysis. And look, we're looking at this episode as diabetes and hypertension. Look, this is something that doctors will be very familiar with, but we'll talk with Dr. Richard Phoon regarding, are we up to date with everything? Are we managing our patients as best we can? And that was the whole aim. Again, doctors manage this; they manage it very well. What can we do better? And that brings us, this is part of the, we're wanting to avoid patients getting to their end stage. We're wanting to identify, and this brings us to the story for this episode. This is actually Dr. Willem J Kolff, and he was born in the Netherlands in 1911. Now, he was very interested in medicine at an early age. His father was the director of a tuberculosis sanatorium at the time, which were not uncommon, but he also encouraged his son to go into medicine. Now, clearly, Willem was very intelligent, entrepreneurial, and he ended up studying medicine at the University of Leiden. He became an assistant of pathology between 1934 and 1936, and he got his MD in 1938. But there was a pivotal moment when he was an intern, and he saw a 22-year-old man who died of kidney failure.
I realized that removing 22 cubic centimeters of toxicity from his blood would have saved his life. I had to do something.
And so he did. And so he found a mentor. His name was Professor Polak Daniels. And he started to work on how do we create an artificial kidney? How do we actually get the toxins? Because that's what kidneys do. They get rid of the waste and toxin from the body. And what they ended up doing was saying, well, if the kidneys fail, then these build up. The patient dies from uremia, and if we could get rid of it, we could save their life. The problem was the timing for all this was the beginning of World War II. And so it was at this time when he's in the Netherlands that Nazi Germany invaded the Netherlands in the 1940s. Now, during this time, Willem's amazing intellect came into play, and he realized the importance of blood transfusions. And so to save lives, he realized that there was a lot of trauma and there was surgery that was going to be needed. And so he actually set up the first European blood bank in the 1940s. Now, this was based on the work of Dr. Charles Drew in the United States, who developed the world's first blood bank in 1937, but clearly had an idea of seeing that this was something that was needed. And with the German invasion, ended up treating a lot of civilians and soldiers using blood bank products. Now, unfortunately, Willem's mentor died during the invasion, and he was unwilling to serve under the Nazis, and so he was sent to work in a remote Dutch hospital in Kampen. But he continued to work on this idea of the artificial kidney. The artificial kidney was not a new concept. This was something that was initially raised in a conference by 3 doctors from Johns Hopkins University. It was Dr. John J. Abel and Dr. Leonard G. Rountree and Dr. Benjamin Bernard Turner. And they described an apparatus that they called vividiffusion. And this was to remove the waste products using a semi-permeable membrane. So you'd have fluid, you'd have blood products on one side, and you'd have a fluid that could take it, and this membrane which things could move between, but you would keep cell constituents on either side.
And this is external of the body?
This is external of the body. And so their concept was sound, but the problem was the apparatus didn't work, and there was no way of, once you got the blood, to return it to the person, and there was no way to maintain the person's circulation because, again, you're taking blood from the patient, and so that can be a problem in itself. And so Willem set to work, and he was able to create the world's first functioning dialysis machine. He used sausage skins, which was cellophane. He used orange juice tins, because that's what they came in those times. He used part of a water pump from a Ford dealer, and he removed a drum from a washing machine. Now, he placed this all into a large laundry tub, and what he called it was a rotating drum kidney.
And it would not have been quiet.
And look, what he ended up doing was he would take blood from patients, he would run it, and it would be able to remove waste products and then return the blood back to the patient. Now, he used this rotating drum kidney, this dialysis machine, on patients who were already dying from kidney failure. And initially he was only able to keep patients alive for a few days. And so it worked, but it didn't work as well as it could.
And also a lot of manual handling.
So, this is the part. I haven't actually seen it work. You can see photos of patients next to these big, large drums and these like tape around the drum. And so I'm guessing when it worked, they must have rotated it around and it pulled, but I'm not quite sure exactly. I'd love to see how it actually worked.
And you wouldn't want to accidentally knock the spin cycle button.
And so the amazing thing about this was his first successful patient that he treated was also his self-described profound moral test.
That's what you say about working with me.
And so this was in 1945, and it was a 67-year-old woman that presented to Campen Hospital in acute renal failure. But she was also a convicted Nazi sympathizer and collaborator. And so this was his challenge.
She was in prison right after the war for collaborating with the Germans, and many of my fellow countrymen would have liked to wring her neck. And she was brought to us in renal failure. My duty is not to wring her neck, but to treat her. And we treated her.
He wrote a memoirs later, and he did wrestle with this, as you can imagine. And so he ended up coming to the conclusion that as a doctor, he had a duty to treat all patients, regardless of their politics or morality.
The moral is that we have to treat patients when they need our help, even if we don't like them.
The patient, it took a week to treat the patient, and she survived. And so he continued to work on the machine. With the end of the war, he ended up shipping machines to England, to Canada, to the United States. By the 1950s, he was actually invited to join the research staff at the Cleveland Clinic Foundation. And then the dialysis machine, again, as you would expect, continued to be refined. And look, Willem even turned his attention to developing an artificial heart, so clearly had an interest in this. Again, that's a story for another episode. But look, we now have these days where we have dialysis. There's peritoneal dialysis, there's hemodialysis. We have about 15 to 16,000 people in Australia who have dialysis, who are on dialysis. It's estimated there's greater than 2 million people worldwide requiring dialysis. And so this is a life-saving treatment, but it's a treatment we also hope to prevent patients needing. These patients often have to go to hospital 3 times a week. They can get themselves into a fair bit of trouble if they become acutely unwell. And again, it's just one of those things that we're trying to we want to prevent people needing dialysis. And so this is why we're looking today at chronic kidney disease. We're looking at diabetes and hypertension. These are the two significant causes for kidney damage, and we're seeing what can we do to help these patients avoid getting to the end stage.
Dr. Richard Phoon is the Senior Medical Advisor at Westmead Hospital and has worked full-time as a nephrologist at Westmead and Blacktown Hospitals since 2007. Richard's a returning guest on this Medical Life podcast for this series on chronic kidney disease. Richard, welcome back.
Oh, good morning, and thank you for having me back.
Let's start with a really important question. Just how common is chronic kidney disease in patients with diabetes?
Our current estimates would be that about 1 in 3 patients with diabetes develop kidney disease. But that being said, it's predicated on patients being tested for kidney disease, and there's probably an underreporting of that, similar to the fact that there's probably an underreporting of patients with diabetes as well. But overall, we estimate that about 1 in 3 patients.
How does diabetes cause chronic kidney disease?
Oh, wow. How long do you have? I guess that's a complex question with regards to pathogenesis, and it involves metabolic factors, hemodynamic factors, growth factors, and also inflammation and fibrotic factors as well. Certainly early in the course of diabetes, we know that there's an increase in efferent arteriolar tone and a reduction in afferent arteriolar tone, both of which lead to glomerular hypertension or increase in glomerular capillary pressure and hyperfiltration. That's an early sign, but later on we also know that hyperglycemia through a non-enzymatic mechanism can lead to production of what we call AGEs or advanced glycation end products, which then lead to glycation of various tissue components, which can lead to organ dysfunction. And then we know that inflammation, fibrotic factors, they play a role. We know that vascular endothelial growth factor plays a role, macrophages are really important, and cytokines. And these all collectively lead to further inflammation, vascular expansion, and arteriolar sclerosis as well.
We're always trying to manage glucose and HbA1c. What's the ideal target range for patients with diabetes to aim for to reduce their kidney damage?
Yep, so we recommend an HbA1c target of around 7%. We focus particularly on the HbA1c because it's a long-term marker of control. But we say 7%. It might differ slightly for some patients depending on the severity of their CKD, because we know that as a patient's kidney disease worsens, that their risk of hypoglycemia can be more significant as well. So depending on the severity of CKD, their risk, and their awareness of hypoglycemia, the target might be a little bit more relaxed. But generally speaking, around 7% HbA1c.
If you're looking at albuminuria, what's the best aim for them?
Albuminuria, as I've said in the previous podcast, is really important in terms of prognosis for patients with CKD in general. And the degree of albuminuria obviously correlates closely with the severity of the kidney disease and the likelihood of their progression of their kidney disease and their complications and symptoms. So generally, we would recommend a reduction in urine ACR of a target of about 30%, or at least 30%. And fortunately, we now have a number of different therapeutic strategies to try and achieve this.
Can you touch on those therapeutic aims about how to reduce that?
Yes, so that's a really good question. I guess the first strategy is lifestyle management for all patients with CKD. And that means healthy diet, regular exercise. If patients are smokers or vapors, they need to stop. And also management of a healthy weight. This should then be coupled with blood pressure control to a target of 130/80, particularly with ACE inhibitors or angiotensin receptor blockers, and then treatments to maintain a healthy lipid profile, particularly the use of statins with or without ezetimibe in patients who are at high cardiovascular risk in particular. And then specific to patients with diabetes and CKD, we'd recommend the use of metformin in patients with an eGFR over 30 as first-line therapy. And then there have been more recent pivotal trials related to diabetes and CKD in the last few years. So then we would look at other medications, including SGLT2 inhibitors, finerenone, and or semaglutide would be another medication as well.
Now, just looking at monitoring for patients, how often would you request bloods and kidney functions and urine to be monitored in diabetic patients?
It takes us back to the CKD staging classification, which, just to remind you, it comprises a GFR or kidney damage, kidney function stage, and an albuminuria or kidney damage stage. And it provides a heat map type framework that relates to exactly what you're talking about, not just treatment, but also monitoring recommendations for patients with CKD, regardless of whether they have diabetes or not. So specifically for patients in the so-called yellow zone, they should be monitored every 6 to 12 months, while those in the orange zone should be monitored every 3 to 6 months, and those in the red zone should really be monitored every 1 to 3 months, looking at those parameters that we've mentioned.
You've touched on some of the medications that are useful. Is there any medications that should be avoided in patients with diabetes or when they shouldn't be treated?
There are medications that we should be careful of in all patients with CKD. So those include benzodiazepines, certain analgesics, particularly opioid analgesics, some antibiotics, antiviral medications. They might need to be careful with those as well. In terms of the medications that I've already mentioned, metformin we don't recommend using when the eGFR is less than 30 because of the risk of lactic acidosis. And certainly when the eGFR is probably between 30 to 45, we'd recommend a dose reduction compared to a non-CKD type of patient. SGLT2 inhibitors are wonderful medications, but rarely they can be problematic for some patients, particularly if they develop intractable and recurrent genitourinary infections, and also the patients who develop euglycemic ketoacidosis. They're rare problems for these patients, though. And then the main concern with finerenone, a medication that I've mentioned, is hyperkalemia. So that's obviously something that needs to be monitored and considered in patients with type 2 diabetes and CKD.
When is it reasonable for a patient with diabetes to refer to a kidney specialist or a service?
The key triggers for referral for a patient with CKD is the same whether they have diabetes or not, and really includes patients, again, with an eGFR less than 30, albuminuria that's greater than a urine ACR over 30, if there's a rapid decline in eGFR greater than 15 mils per minute per year, or a 25% or greater reduction in eGFR over 12 months, or if they've got resistant hypertension. And I guess the caveat is if they develop any complications that might require nephrology input. So particularly if they develop CKD-related anemia requiring erythropoietin, that might require them to be referred a little bit earlier as well. And again, it's really important to understand that there's this health inequity. So First Nations Australians, we recommend that they are referred to us sooner with an eGFR of less than 45, or if their kidney functions decline by more than 10 mils per minute per year.
Does that mean with First Nation Australians you tend to go more aggressive early for treatment? Is that one of the approaches?
Yes, so I guess the reason why we ask for First Nations Australians to be referred earlier is because we know that they have worse outcomes. They're overrepresented in terms of patients who have CKD, but also in terms of kidney failure requiring dialysis and or transplantation. So for that reason, yes, we were asked them to be referred earlier. The recommendations are probably not really dissimilar to the non-Indigenous population, but we need to see these patients earlier so that we can guarantee that they're going to have treatment at an appropriate stage.
There is one moment, I did get a question as regards to when do you consider a kidney biopsy in patients with diabetes? Because it's so prevalent that people with diabetes do get some kidney disease. When would you actually consider doing a kidney biopsy on a diabetic patient?
Yeah, that's a good question. And I guess that's probably something I left out in terms of the referral guidelines, because obviously if someone requires a kidney biopsy, that's not able to be done in primary care. But the patients in whom we would be concerned that they have a diagnosis other than diabetes, they're the patients that we're looking at in particular to do a kidney biopsy. So patients who have only had a short history of diabetes, that would be suggestive that it's not diabetes. If patients have glomerular hematuria, that would be suggestive that they might actually have a glomerular cause of kidney disease other than diabetes. And if their kidney function is declining more rapidly than expected with the parameters that I mentioned earlier.
Richard, we're about to regroup in a minute and look at hypertension and CKD. But before we do, is there any final advice you have for doctors regarding diabetes and CKD?
Yes, I think it's about screening, diagnosing, and treating these patients early. You can refer if necessary, but now there's plenty of medications for you to be able to use in these patients in primary care without needing to refer.
We continue our discussion with Richard now, and as I mentioned before, we're about to turn our attention towards hypertension and CKD. I guess the $64,000 question is, what is the ideal blood pressure for kidney health?
Wow, so $64,000, that's a bit of a lowball offer, actually. So I guess it depends on how to interpret that question. But certainly for patients with CKD, whether they have diabetes or not, we would recommend a blood pressure target of 130/80. If your question is, what should your blood pressure be to prevent kidney disease? We know that the commonest cause of kidney disease is hypertension followed by diabetes, or diabetes followed by hypertension, sorry, but they're both very common causes. So we would recommend that patients aren't hypertensive if they're going to maintain kidney health. Hypertension would be defined as a blood pressure over 140/90. So to prevent kidney disease, I'd aim for a blood pressure under 140/90. Normal blood pressure these days, we would say, is under 120/80, to be honest. And that sort of 130 to 140 systolic mark we'd call high normal. So those patients would need to be monitored closely. But in general, blood pressure target of 130/80 in patients with CKD, and avoid hypertension if you don't want to get kidney disease. So keep a blood pressure under 140/90.
How does blood pressure cause kidney damage?
So that's another more than $64,000 question. Look, long-standing high blood pressure leads to a number of changes. It leads to hypertension in the glomerulus itself and hyperfiltration, which leads to damage, scarring, and sclerosis of those glomeruli. It can also lead to arteriolar sclerosis, glomerular ischemia, hypoxia, and tubular interstitial fibrosis as well. And then we also know that inflammatory mediators and reactive oxygen species in particular play a role in terms of how high blood pressure causes kidney disease.
So we're looking at the 140/90 as being the cutoff for blood pressure, aiming for 130/80. Does that recommend that you would probably say start that 140 is the actually higher end, and it would actually be better if we would treat it earlier, or is it 140 is just the cutoff?
140 is the cutoff for definition of hypertension. The recommendation is obviously, if I always say for most things actually, is one swallow doesn't a summer make. So obviously, if you have a patient who presents with the blood pressure of 140/90, it's important to make sure you measure it and repeat it to make sure that it is persistently elevated, or if it's truly 140/90. So the ways to do that would be either using home blood pressure monitoring or ambulatory blood pressure monitoring to confirm that. And then in terms of management, if a patient truly does have blood pressure over 140/90, I'd still look at lifestyle modifications, weight loss, dietary modifications, particularly a low salt diet. We talk about the DASH diet. So they're useful strategies for managing patients with hypertension in that low, 140 sort of mark. But for other patients, if they're not responsive to that, or if it's even higher, then they might require therapy for their blood pressure.
I get asked this a lot because there are multiple times when patients are on multiple antihypertensives and they can't bring it down. When do you start considering secondary tests for like resistant hypertension? Is that something that's really rare, or is that something that you would recommend doing more often?
So there's a couple of points I'd make about that. Firstly, yes, you're right. Patients are often on multiple medications. And if you look at the hypertension trials that have been done over the last several decades, most patients are on 2, 3, or 4 medications. So that's really very common. So in the first instance, I just wanted to say that the recommendations these days is probably that you should be erring on the side of treating patients with combination therapy up front, not just with one medication, because it's more likely to be used in those patients. It's more likely to be more effective, and it probably helps compliance with these medications as well. If patients have truly treatment-resistant hypertension, or I would consider other causes other than essential hypertension in patients who have early onset hypertension, particularly patients under the age of 30, severe hypertension, blood pressures of 180 or more, or resistant hypertension, as you say. And so for those patients, you'd be looking at whether they have underlying kidney disease. That might be a cause of their high blood pressure. Also, renovascular causes, so renal artery stenosis, fibromuscular hyperplasia, particularly in the younger patients, endocrine causes like primary hyperaldosteronism in particular, and also obstructive sleep apnea is very common as well, and that's something that should be looked at too.
Is there some tests that you consider when you're doing that? Like, you've rattled them all off beautifully, but is there almost like a list that you sort of do then when you're requesting?
Yeah, so for those patients, I'd look at their kidney function. So I'd look at their UECs. The UECs is also useful because it can provide their potassium level. Potassium might be low in patients with primary hyperaldosteronism. I look at their thyroid function test because of the association with thyroid disease and hypertension as well. Urine albumin to creatinine ratio is important to look for both kidney disease, but also any end organ damage that may be related to their hypertension. Plasma aldosterone to renin ratio is useful for patients if you want to look for hyperaldosteronism as a screening test. You could do 24-hour urine-free cortisol. Look also at plasma metanephrines in patients if you're thinking that they might have pheochromocytoma. And then also a 12-lead ECG is useful to look for signs of left ventricular hypertrophy. That's the general sort of test that I might do. So for some patients, also a urinary tract ultrasound might be useful. Look, I guess in terms of looking for renovascular disease, I guess if you ask 5 nephrologists, you'll get 5 different answers. But I would normally do a renal artery Doppler scan. It's a bit time consuming. It might take about half an hour per kidney, but that way you can look at the kidney arteries. But also you can look at the so-called resistive index in the kidneys themselves, which might suggest whether they've got intrinsic small vessel disease in the kidneys that might be causing their hypertension.
Richard, I'm just curious. I get the sense as a layperson, a sample of one, kidneys are just not talked about very much. Other organs get a lot of attention. Travis is now chuckling. Have I stepped into something here? Or am I completely wrong?
No, you're completely right, and don't worry, you're not alone.
Okay.
So it isn't talked about enough, and I think that we all need to do our bit to make sure that kidney disease awareness is much better appreciated in the general community, but also in the medical community too. I think that patients in general, the community in general, don't think about kidney disease, partly because they don't develop symptoms from kidney disease until very late. And generally just because it just doesn't get much recognition. So I think that is problematic. I think in terms of medical practitioners, I don't think, I think it's still underappreciated. I think that, we now have patient practice management tools, electronic medical records and those sorts of things. And I think that if people use their practice management software appropriately, you can audit and find these patients a lot more easily. And now we have treatments that are very effective for these patients.
With some of the medications, are there some that are more useful than others, or are there some to avoid?
For patients with hypertension, yeah. So hypertension and CKD, or hypertension without CKD, I guess. For hypertension without CKD, we would recommend, from a hypertension point of view, ACE inhibitor or angiotensin receptor blocker, but not both, a calcium channel blocker and or a thiazide diuretic. So the treatment options are a bit varied, but as I said, I think that combination therapy is probably the most useful for most patients with newly diagnosed hypertension. In terms of patients with hypertension and CKD, I'd still be pushing the ACE inhibitor and angiotensin receptor blocker in particular, with less of a focus on calcium channel blocker and or thiazide diuretics. But again, patients often require multiple therapies, and a calcium channel blocker in particular is a very useful combination to have with either of those medications.
Do you have a preferred diuretic that you like to use or recommend for patients?
So I guess it depends on the patient. So, it's not a one size fits all for both the diuretic and the patient. I think that if you're just treating their hypertension and they don't have severe or moderately severe kidney disease, a thiazide diuretic might be quite useful. If they have more advanced kidney disease, and fluid overloaded is an issue, sometimes a loop diuretic, furosemide, might be particularly useful in those patients. And obviously, offloading the excess fluid that the patient has might be quite useful in terms of not just getting rid of the excess fluid, but also managing their high blood pressure as well.
Now, how often do you check things such as kidney function like eGFR when you're starting treatment, or just with ACE inhibitors or angiotensin receptor blockers?
My recommendation would be to repeat the patient's UECs about a week after commencing ACE inhibitors or angiotensin receptor blocker agents to monitor both their potassium and also their kidney function. Obviously, you want to keep their potassium within the normal range, ideally, but also an up to 25% stable reduction in eGFR would be acceptable. Because we know that the way that ACE or ARB agents work is by reducing glomerular pressure. So we would expect some reduction in the eGFR. Up to 25% reduction has been shown to be acceptable and still leads to long-term benefit. But it also means that if the eGFR is reduced after 1 week, you really need to remeasure it another week or two down the track to ensure that the decline doesn't continue and that it has plateaued at that level.
And does anything like acute illness affect the medication, or when it should be stopped?
We use a mnemonic, or we recommend a mnemonic called SADMANS. So it's a bit sexist, really, isn't it? But it's useful for patients who have an acute illness and really highlights the medications which should be avoided at that time. So these include sulfonylureas, ACE inhibitors, diuretics, metformin, angiotensin receptor blockers, NSAIDs, and SGLT2 inhibitors. That's the SADMANS mnemonic. But just as importantly as when to stop it with an acute illness, it's important to remember when to recommence it. We know that there are a number of patients that they stop their medications and they never get back onto it again, which is really bad for their long-term outcome. So it's really important, yes, to consider when to stop it, but also to consider when to reinitiate therapy once the acute illness has passed.
Gee, that SADMANS mnemonic just rolls off the tongue, doesn't it?
It does.
I'm not sure writing greeting cards is in your future. That's all I'm saying. Just finally, do you have any advice for doctors when they're dealing with patients with hypertension and CKD?
Well, again, same for diabetes. Screen, diagnose, and treat early. That's my hallmark card. Mnemonic. So screen, diagnose, and treat early, because that's how you can yield the greatest benefit for these patients. And you really need to encourage patients to be involved in looking after themselves. So particularly with patients with hypertension and CKD, I recommend pretty much all of them to get a home blood pressure monitor so that they can monitor their blood pressure, and so they're aware of their targets and how to manage it as well.
Thank you very much. And even since I first met you in the last episode, I deliberately have reduced salt intake in the diet. So you're already one by one having an impact.
Wonderful. Great to hear.
Dr. Richard Phoon, thank you again for being part of This Medical Life.
Thanks. Have a great weekend.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.